Good Monday morning, everyone. I'm Jessica Lovell, in for Dr. Steve Stites, our Chief Medical Officer. He's taken some time off. We are coming to you live from inside the Dolph C. Simons Jr. Family Broadcast Studio. So glad you're with us today. So with us also in studio is Dr. Marc Parrish. He is from Maternal Fetal Medicine. And we're going to dive deeper into the CDC report linking premature and even some stillborn deaths to COVID-19. So we'll talk more about that in just a little bit. So good to have you, Dr. Parrish.
Thank you for having me.
And Dr. Dana Hawkinson, our Medical Director of Infection Prevention and Control. He's going to update us on the numbers. How did we do over the weekend?
Yeah, not too good. So certainly for the Kansas City area, as far as number of cases, it looks to be down a little bit over the 7-day rolling average, but that could be delays in reporting, especially in the weekend. As far as here at the health system, again, not very good. We want to keep those numbers down as far as hospitalizations into the low 20s, teens if we can. We have increased the past 10 days. We're up to 33 inpatients in the hospital right now. A third of those, 10 of those are in the ICU, but luckily only 3 of those are on the ventilators. So that is good. We do have less people who are in that recovery stage at 19. So they meet discontinuation criteria for some of the PPE. But in general, that's still 50 patients who are in the hospital who really shouldn't be otherwise. So, and in Hays, and our partners in Hays, they have actually 18 acute or active COVID infections right now as well.
I was listening this morning about just how the rise is starting kind of in the Midwest, northern part of the country. Concerns that it's going to trickle back down here. What are you thinking that's coming from?
Yeah, I mean, I think there's, again, with all of this, there probably will be fluctuations from day to day, 7-day to 7-day rolling averages. But in general, again, I think we are getting out of the outdoors season. There are people moving indoors. We know school is back in session as well. It's difficult to say if those cases are due to actual school infections, or is it when again, people who work at the schools are out in the community, or the children are getting together outside of the school area and doing their things, as young people do, and if those cases are going up because of that. We certainly do know that a large proportion now, compared to earlier in the summer and spring, a large proportion is in that younger age group, especially that 20 to 29. So.
Yeah, my daughter starts back full time today, full capacity. So I have questions for you. And who's your friend?
Yeah, well, this is, Patrick Mahomes. He's our
safe.
Yeah, he's always safe, doing things a safe way, wearing the mask, and yeah, he's a very good ambassador for our community. So if they play tonight, hopefully we'll get a win.
Yeah, absolutely. All right, Dr. Parrish, how are you today?
Great.
Good
Thanks
to see you. Saw you a lot pre-COVID, and now I haven't seen you, so nice to see your face.
Yep.
So for folks who don't know about the CDC report, kind of summarize exactly what it's telling us.
So the CDC a couple of weeks ago updated a report that they'd actually put out originally in June to try to provide updated guidance on what was occurring in our pregnant moms who were tested positive for COVID-19. In this series that they released a couple of weeks ago, there were 600 pregnant moms, approximately 600, and they showed that there were increased risks for some specific adverse pregnancy outcomes. Some of the numbers that jumped off the pages at us originally were the preterm birth rate was 25% higher, is what the headline showed. And then there also was an increased rate for miscarriages as well as stillbirths. When you look at this data a little more closely, however, the numbers may not be as shocking as what the initial headline showed. For instance, preterm birth rates in this study were 12.5%. The national average on an annual basis is about 10%. So it is increased a little bit in this subgroup of patients, but it's not a tremendous increase in the risk. Where I found it somewhat interesting is that when you dove deeper into the data, it was those moms that had symptoms where the preterm birth rate was actually being driven up. And so typically these are the moms that are going to likely be admitted and be sicker. That possibly can affect how the baby is doing and could result in one of two things. The first being a nervous provider saying, okay, we've got a baby that's likely going to do well outside of mom's incubator, so let's just deliver, because we don't know how sick mom's going to get and what type of effect it's going to have on the baby. But on the other hand, there's a possibility that she could just go into spontaneous preterm labor. We know that in other situations that can result in moms having this massive inflammatory response in their system, that can trigger preterm birth. So we don't know from this information what was causing those preterm births. Was it nervous physicians? Was it an actual spontaneous preterm labor that was occurring? That's definitely more to come from that. The British Medical Journal actually just a couple of weeks ago as well set out this meta-analysis of 70 different studies that showed the spontaneous preterm birth rate was only 6% in their numbers, and they had about 8,000 some people in the study that they had released in their meta-analysis versus the 600 in this one.
So as if expectant mothers don't have enough to worry about, so now you have COVID on top of it.
Right.
What are you hearing from patients? Because
Yes.
that would be really scary. I can't imagine.
Lots of anxiety, not surprisingly, and I typically say that we are learning more and more, but even though the numbers may sound somewhat scary on the TV reports they're seeing or anything they're reading online, the absolute risks for an adverse problem occurring in their pregnancy to them or to their baby is very low.
So advanced maternal age, we talk about age and COVID a lot. Does that have anything to do with it? Can you bring age into it?
Yeah, absolutely. So age plays a significant role. Pre-existing medical conditions, obesity, diabetes, hypertension, all these things are very common things that many of our moms do have, and we're a little bit skewed because we take care of a higher risk population. So not all moms obviously are falling into categories that have these pre-existing morbidities that can increase the risk for a bad outcome to occur in pregnancy. But it certainly enhances those chances of moms being sicker if they are older or they have pre-existing medical conditions.
Right, which we would talk about for COVID anyway. So have you experienced any of this, Dr. Hawkinson? I'm sure you get a lot of questions from people, and I would imagine if you had a friend whose wife was pregnant, they would be asking you, what should I do? And do you have any advice for women?
Yeah, I think initially, when all of the COVID, the pandemic started, especially in the other countries when the information was coming out so quickly, there wasn't a lot of information about pregnant patients. As we got to our experience here in the United States, there seemed to be more, and now there's certainly more evidence coming out in general from around the world about pregnancy. We thought it really certainly wasn't as bad as influenza. I think people can make that argument, especially obstetricians can debate about that. There was that headline about pregnant women are more at risk to go to the ICU. But just as you talked about, if you deep dive into that information, it was 0.9% of pregnancy going to the ICU compared to 1.5 if you had COVID. So even those numbers, although I think they were statistically significant, wasn't a great increase. And so I think it just goes to the same things. Certainly you don't want influenza. So continue to do those safe practices, talk with your medical team, your obstetrician, and really protect yourself as much as possible.
Are your conversations any different, especially right now as we enter into the flu season, just making sure that women are getting their flu shots if they're pregnant?
Absolutely, and I think that is a very strong point that we need to continue to hammer on. And we even have data that will back that up, that just says there was a report in 2009 of pregnancy outcomes in those that had the flu. And if you look at the mortality rates in that group versus the mortality rates in our COVID moms, it's 12 times higher in those moms that had the flu than it is currently on the data we have in our COVID positive moms. So it's very important that we emphasize to our moms, and we have been, get your flu shot, do all the other things that Dr. Hawkinson's team is telling you to do. Wear your mask, social distance, good hygiene. If you do these things, you're going to have a good outcome and you're going to stay safe.
I know when I was pregnant and my doctor told me to get a flu shot, we were entering flu season, it was a little scary. I was like, are you sure? Are you sure I'm supposed to do that? So I'm glad you mentioned that, because I think a lot of women might say, maybe I can hold off this year, but you're saying absolutely not anyway, regardless of COVID, right?
Absolutely, yes. The flu shot has been shown over year after year after year to be safe. There's no adverse effect on the baby. There's only benefit, no risk.
Okay, so if and when the COVID vaccine comes out, how in a hurry will you be to recommend women getting that?
So it's a great question, and I'm a little biased. I'm going to push more for it, but it's going to be difficult to argue that, because right now, if you're pregnant, you're not eligible to be involved in research studies, which I think that's not a fair situation. But again, my opinion is biased. If you're an outsider looking in, you would ask, well, why put the baby at risk of something that is not known? What are the effects on mom? But the pregnant moms are a vulnerable population. I think that they should be eligible to receive the vaccine after we've gone through some very rigorous, which I know is already happening, safety trials to give us that information to prove that it is safe in non-pregnant population. But when and if it is released, we're going to advise that moms get it.
When? And have you had any mothers say that they would go into a trial if they could?
I've not had anybody that's come out and asked, hey, do you guys have a trial going on here?
I'm not surprised.
But I'm sure we'd have some, especially our moms that are the pregnant moms that work here, that are either physicians, nurses, medical assistants. I think they see the type of risks that other disease processes cause or result in adverse pregnancy outcomes, and I could see them stepping up to the plate and being interested. So
Dr. Hawkinson, then that's kind of an issue, because you're right. No pregnant woman is going to jump right in. I mean, maybe some would, but I mean that's going to be a challenge when we find out what the results are going to be for pregnant women. What are your thoughts on that?
Yeah, absolutely. I think, as you stated, we really need to make sure, and if we can allow this process of developing these vaccines and going through these studies to look at safety and efficacy, if we can allow the scientists and the research community to do that without external forces and pressure, and do it as the scientific method, as we have proven over and over with various vaccines and treatment, we can then get to a point where we can study it in the pregnancy population, make sure that it is safe. Again, most of these vaccines are only really pieces of the virus, so it's not really going to be a problem to cause the infection, so it should be safe as far as that goes. But as we move further into this, if and when we do get the vaccines approved, they should already be safe, and at that point we can reevaluate to see if it's safe in pregnancy.
All right, I have lots of questions for both of you, but I know I have to stop and ask our public for some questions. Jill Chadwick, standing by in her Chiefs thread over there. Hey, Jill, good morning. Let's ask some for some media questions. Any reporters on the line today?
Hi, good morning, guys. This is Taylor at Channel 41.
Hey, Taylor.
So I have a question for Dr. Hawkinson this morning that I'm going to challenge him to see if he can answer this question without using the term viral load. Because, just making sure, how well people can follow along. We were talking about this morning, is it possible to get, for lack of a better phrasing, a little bit of COVID from someone? Like, are there variances in how much you can, if it's just a passing situation where you may get somebody walk by and come in contact with them, or you get a full-on blast, so to speak? How different is that?
Is that a little bit like being a little bit pregnant?
Yeah.
Maybe we should be asking the other doctor. No, I'm just kidding, Taylor. Go ahead.
So that is a very good question. Again, for infection, we really continue to talk about intensity of exposure, so time and proximity. Closer time and closer proximity is going to give you more chance of getting infection, if that's what you're talking about. Certainly just moving by somebody, if you're walking outdoors, is probably going to be really less to no risk at all. Without using that term that you mentioned, from some mouse studies, we do understand that it probably takes about 200 viral particles or infectious viral particles to become to cause an infection. So that's a very small amount of virus. That is what we need to consider when you're in any situation, that it really takes a small amount of virus to have infection and develop infection. Again, it's a mouse model. It's not the best, but it is the best we have right now. So even a very small infectious amount of virus could cause the infection. So if just walking by, probably it's not going to be a big issue, but if you are in certain proximity of somebody who has it or in that area, you have much greater risk of getting SARS-CoV-2 viruses and then certainly COVID-19, the disease. Does that help?
Yeah, so I guess to nail it down, the severity of my symptoms and me getting the virus is not affected by how much time I spend around somebody. If I've got it, then the symptoms are entirely dependent upon me. It's not how much time I spend around someone.
You know, that's a good question. We still don't know that either. We know that people who have severe illness can tend to have higher amounts of viruses that we can detect. Is the amount of virus you get infected with, does that have any bearing on what your disease process is? We don't know that for sure. There is some thought that if you don't have a lot of virus, maybe some of those things that the virus does, such as the immune evasion, evading the immune system from it and not letting it act correctly when it does come into contact with the virus. Maybe if you don't have enough virus, you are not having as much immune evasion from that process, and your immune system can catch up quicker rather than if you have a large amount of virus that you get infected with initially. A lot of that immune evasion takes place. You have a lot of viral replication, and by the time your immune system is working, it then starts to go into overdrive and you can have that dysregulation. That's a good question. We don't fully know the answer to that, but that is one thought as well.
Perfect. Thank you very much.
Yep.
Thanks, Taylor. Any other questions from reporters this morning? All right, Jill, I think you're up.
All right. Jared writes, we have 18-month-old twins. Our babysitter tested positive for COVID-19 and told us on Friday. Saturday, I got a rapid test and says I'm negative. Am I good to go back to work? Some friends say I should have waited until day 7 or 9.
Mm-hmm. Yeah, that's a good question. So now the CDC has recommended testing for everybody, especially if you're a close contact. They haven't given really any guidance of when to do that. Is it 2 or 3 days after exposure? You have to understand, so you're counting the time from the last exposure. Most people would advocate not doing it 1 or 2 days after your initial exposure, but rather waiting 5, 7, 8 days from your exposure or your last exposure to that known case. Unfortunately, testing, though, does not get you out of the 14-day quarantine. Even if you test negative, you need to continue to maintain that 14-day quarantine.
So the dad was tested, not the children, correct?
Right.
Yeah.
Okay. Dr. Parrish, do you get questions about that? I mean, I know you deal with the mothers, but I'm sure in the line of work you're in, you get a lot of questions about my little ones, especially small infants, may have been exposed. What do you hear about that?
So definitely, I think it just kind of falls into this category of just this anxiety, and the unknown. And so we get similar questions. So what we're just posed to Dr. Hawkinson, about other family members, friends. I've been exposed to somebody at work possibly. I rode in a car with somebody, and so we're trying also. I know that you guys are always looking at the data and seeing what the CDC is recommending. We're trying to stay on top of it as well, so that we're not giving our patients false information. But a lot of times, if we're not 100% certain, then we're going to pick up the phone and call somebody that may have the latest data. But usually we do pretty good at trying to stay up to date, just because we know we're going to get those questions fired at us as well.
Sure. Jill?
Becca asks, now that it's getting cooler, how safe is it to meet in someone's garage with the door open with a small group, less than 10?
Mm-hmm. Yeah, so this goes overall to risk mitigation and your tolerance for the risk that you are going to enter yourself or your family into. This is another one of those. Certainly, this goes back to the basic. Outdoors is always better than indoors. Certainly a garage with a large garage door open is not going to be as good as outdoors, but it's going to be better than being indoors in an otherwise confined space. Hopefully you will get some breeze or wind through there, having turbulent air, so the virus is dispersed and falls to the ground. But again, it goes back to it is still semi-indoors compared to a full outdoor, say, is on a driveway. Can you make sure you can do that spacing within that area? Again, 6 feet, we've said certainly 8, 10 feet is better if you can. And it's just a matter of understanding those concepts. The masking is vitally important. The distance is vitally important. Outdoors is better than indoors. If you can understand and grasp those concepts in anything that you're thinking about doing and try to reduce your risk that way, that's going to be the best way moving forward. So it's still more risky than being outdoors, but again, with a large garage door open, it is probably less risky. Hopefully you do have that turbulent airflow. Hopefully you can still space out within that space as well.
Yeah, driving in today, they were talking about how cooler temperatures are going to bring on that concern that we've been waiting for. We were
Yes.
put on lockdown in the middle of the spring, this beautiful weather, and now everyone's back inside.
Right.
Do you have concerns about that?
Yeah,
The numbers?
absolutely. People, as Dr. Lisbon said, we are social creatures. Human are social creatures. Pack animals, we want to be with our loved ones. We want to be with our friends as well and doing things. Outdoors in the spring and summer, it's a lot easier than when it gets colder. So I think that is a concern. Hopefully we won't have a new large surge as they're seeing in Europe, and I think some other communities are as well. But time will tell. And just understand that the indoor spaces are going to be more at risk of spreading the disease.
Jill?
Scott writes, COVID numbers are up in 25 states again, and it was reported that the U.S. has passed 7 million cases. What is your prediction for the fall? Where do you think the numbers are going to go?
My prediction, it will continue to expand. Again, I don't have necessarily any other new modeling information other than what's put out there. There are several large institutions that are doing modeling for this. And they change as the data change, but as we're moving forward, again, we understand that cooler temperatures, as we talked about, people are going to be doing things inside, wanting to get together inside, even if it's not a bar or a restaurant, if it's at a home, and if you have 10, 15, 20 people in that home, you have to assume 1 or 2 of those people probably have it. If you are inside in those enclosed spaces, it's going to be very easy to transfer the virus from an infected person who may or may not know they're infected to other people who are susceptible. So certainly we do expect that there will probably be an increase or a surge or a second wave. We just don't know how much, and we have to just continue to give our message and understand and hope that the listening public really understands those concepts of outdoors is better than indoors. Do the physical distancing, do the masking, don't meet in large groups, things of that nature. Hopefully we can really not have a large surge to affect our supply chain for our food and our other daily things that we need, but also for our healthcare systems so they are not overwhelmed as well.
Dr. Parrish, I have a quick question for you, though. I was wondering, are families putting off their family plan due to COVID? Are they? And if they are or are not, are you recommending that?
So we certainly are getting those questions. We've not observed any decrease in pregnancy rates just on a subjective experience here at KU. But we've had some preconceptual consultations for patients that have other medical conditions, and that question does come up. Is this extra dangerous for me to become pregnant during a pandemic? And, our answers typically have been, if you have the motivation to have a family now, there's no reason to delay it. If you're taking care of yourself, following the guidelines, even though you can look at data that are publicized, they're going to be scary numbers oftentimes. But if you dive deeper into this information, you observe that really the risks are very low. You're probably at higher risk for whatever pre-existing medical condition that we're discussing at this consultation for an adverse pregnancy outcome than COVID-19 is going to result in. And so I encourage people that if they're ready to go for it.
All right, thanks. Because I think a lot of people read these studies and they do get nervous. So thanks for helping us better understand that and those numbers. Jill?
Yeah, Vanessa has 2-part questions. So her first question is, what % positive are you seeing in your pregnant patients, laboring patients?
Yeah, so we've had 72 patients total in our system just for OB, the obstetrics labor and delivery unit, where moms tested positive, and the majority of them have been asymptomatic because of the universal screening that we've instituted here. So when it comes to the number of moms that have actually have labored that were positive, it's a small percent. And typically in those that were positive that labored, they did very well. There were no complications during that process.
Her second part is, what are your thoughts on allowing a second person for labor support?
So right now we're doing our best. I really think that a lot of our moms would benefit from having not only one support person from the family, but oftentimes they have a doula or some other pregnancy support person with them. Right now, even though I see the benefit in that, I feel that there are more risks by having too many people coming into the hospital. And so for now, my opinion is we've got to keep it to just one support person in the room.
That's tough, isn't
That's
it?
how I was just thinking. I was like, wow. I was going to ask you, is it still just one? Because I can't
It is.
imagine going through this
Right.
really, which is supposed to be just this glorious time in your
Right.
life, and now you're dealing with this. I can't imagine.
It's very, very difficult because, again, as Dr. Hawkinson pointed out, we're social creatures. We want to be with our family, and the birth of a child is such a huge, a part of somebody's life. And so grandparents, aunts, uncles, everybody wants to be involved. Everybody typically would come to the hospital and congregate in the patient's room afterward, and that's not happening now. And certainly you can see why it's a risk situation, but we also sympathize with the fact that if it were me, I'd want the same thing. Unfortunately, right now, we have to stick to the one visitor, one support person rule.
How are moms handling that? Is that a whole other issue, or are they just rolling with the punches?
At this point, they're rolling with the punches. Initially, there was a lot of moms that were understandably upset. There was a point, and we never got to this point, but there were some hospitals in New York City, for instance, that allowed no support people in. And so I think they're looking at, well, it could be worse. We couldn't have we may not be able to have anybody here. So I've not heard a whole lot of grumbling about that.
They just have a healthy baby, and they're probably pretty happy about that. Good mom and baby time together.
Yep.
Jill?
Mary Lee up in Northwest Missouri wants to know what you think about herd immunity. News reports have been saying there may be no such thing for COVID. She wants to know, what do you say to those who encourage it?
Yeah, I think herd immunity is probably not realistic. Number one, there's new published results saying that really just maybe about 10% of the United States, this is based on seroprevalence data from people donating plasma and blood, have had infection with it so far. So if you think only 10% of the United States, and look at what's happened already as far as number of cases and number of deaths, if you get to that 90%, again, historically, herd immunity has said to be about 90%. And since COVID came in, some people are saying 50 to 75%. But historically, herd immunity means about 90% of the people are protected either from past infection or from vaccination. So if we're getting from 10% right now to 90%, if herd immunity actually did work, imagine the devastation that we would have with the amount of deaths and new infections. However, we understand that just typical cough and cold coronaviruses, people can be reinfected with those, several months, so 6 months, 9 months to a year later with the same exact virus. Now, will they have the same exact clinical situation? Probably not, but we know that people can be reinfected with the same common coronaviruses after already having infection, at least within 1 year or 2 years. So herd immunity is going to be very difficult to obtain. We also understand that people can get reinfected. We've had 2 very well done studies showing that there were 2 patients who were reinfected with coronavirus or SARS-CoV-2, and they had different clinical presentations. One person was asymptomatic, and the other person had more symptoms and had to go to the hospital compared to their first infection. So herd immunity right now is probably not the way to go, and not what we should be looking for, but it's continuing to do the non-pharmaceutical interventions, the distancing, the masking, the hand hygiene, but also hopefully a vaccine will offer some protection as well. And as we get further into this, Also, having better therapeutics, maybe even therapeutics that we can use at certain time frames within that infection. So early on, things like monoclonal antibodies or plasma, but also maybe even, say, just pills that we can take, kind of like Tamiflu that we do for influenza, some antiviral that we can take as an outpatient rather than, say, like remdesivir, which really now is only IV and used for hospitalized patients. So, but to answer the question, herd immunity probably right now is not the best way to go, and we don't even know if having coronavirus once will offer you durable immunity so that you can't get it again. Certainly it doesn't seem like that.
Dr. Hawkinson, can I ask my school question of the day? Because I know I'm not the only parent sending back their kids today at full capacity. So I was a little concerned as I was driving in today, but should I be concerned that my kid went from 9 kids in their class now up to 18 kids in the class? Seemed a little early to me. What are your thoughts?
Yeah, I think there's always need to be concerned. Again, we understand the virus is out there in the community. That's the first thing. So take measures to prevent that. We know that as people come together, there's more risk of spreading the disease. So the ways to prevent that is masking. If those children in that room can be masked, that's a very good thing. If they can be as far apart from each other as they can within that room, that's a good thing. The teacher as well, but also the administrators and the other adults in that school, whether it's counselors or other support staff as well, maintain those distances. We know that when both parties are wearing masks, it's going to really cut down on infection. The other thing is, since it is out in the community, we understand that people are going out and doing things, and we don't really know, and hopefully we will get more information as now these schools have been opened up for weeks and a month, a couple months. Is there a lot of, although a lot of people are being quarantined because they're coming into contact in the school, and some classes or grade levels have to be out on quarantine for 14 days, is there a lot of spread within the school, or is it the community? And so hopefully we'll get more information about that.
Yeah, because just because someone gets it doesn't mean they got it at school.
Correct.
So
Yep.
keeping that in mind. Jill?
All right, Amanda asks, if someone tested negative 1 week after exposure, and they ask, why do I still have to quarantine for the remainder of 14 days? What is your expert answer? And when will we have enough data that this situation of a negative test says you're safe and you're good to go?
Yeah, I don't think we'll ever have enough data. We're certainly looking for that. We understand that the incubation period, meaning the time from infection till you develop symptoms, is 14 days. That's pretty standard. That's been around really since day one. Obviously, that is continuing to be looked at. We do know that we did, we had an employee here who was exposed, was never tested, was doing quarantine, but at the 12-day mark developed symptoms. So if we would have tested that person at 7 or 8 days after exposure, they would have been negative. So we understand that it can take up to 14 days or sometimes even longer on those outliers to develop symptoms. That's why the 14-day quarantine is so important, because the incubation period can be up to 14 days in some people. So even testing at that 7 or 8 day after exposure, you could be negative, but that test that we do, the PCR test, is really only good for that day and that point in time, and it doesn't really speak to what is happening 48 hours later. You can then develop enough viral load or virus to be detectable and be infectious to others. So that's why it is the 14 days.
So how do you know if you should wait? Should you wait to get a test or get it right away?
Again, there is no good guidance on when to get tested after exposure. We would certainly recommend probably that 5 to 8 day mark. But again, even testing negative will not get you out of that 14-day quarantine. It could offer you some peace of mind, for sure, and give you a direction to go in and at least know you're negative at that point. Or if you know you're positive, then certainly isolate for those 10 days after that diagnosis as well.
Do women have to get tested when they come in to give birth?
Yes,
Okay.
it's part of the universal screening. So any planned induction, or if they get admitted for another reason and they're going to stay at least one night, then
Okay.
they automatically get tested.
So that's just standard.
Standard, yeah.
Got it. Jill?
Jamie has a question I don't think we've been asked, and I'm kind of surprised when I read it. But she wants to know if you're a caretaker for someone who is suspicious or tested positive and you need to take them to the hospital, what's the safest way to do that? She said, I know I need to put my mask on, but open the windows, turn on the air full blast?
Yeah, that's a good question too.
Put them in the back seat?
So certainly masking of that patient if they can tolerate it, if they aren't too ill, is going to be the best. You're going to give that barrier protection, and that's really what we want. Certainly distance, if they can be in the back seat, or if you have a van or another larger car in the further away from the driver as possible will be good, but certainly masking is needed. Understand your route so you can do the least amount of time as possible to get to that facility. Open windows are certainly reasonable as well. That'll cause a lot of turbulent air, but as it gets colder, that might be a little bit more difficult. So I think the first thing you understand is the barrier protection of that person that is infected. So get them to wear a mask if they can and tolerate it.
Jill, a couple more questions?
Yes, Ruthie wants to know, are there many people 70 plus that are asymptomatic?
Yeah, I don't think we know that. I don't know that there may have been some presentations on that. It's hard to really know. I don't know the full demographic breakdown of percentage of asymptomatics within that group. I would assume that there probably are. I know that I did take care of a gentleman who was admitted and on pre-screening for admission was positive. He was in that age range, and he didn't have any symptoms throughout his quarantine period as well. So it does happen, but probably less frequency, with less frequency than with the younger populations.
Last question?
Sure, let's do it.
All right, Michelle wants to know, I've read that we should get the flu shot a bit later this year for max protection, since social distancing, hand washing, and etc. may delay the peak of the flu season. Mm-hmm. And she wants to know your thoughts on that.
Yeah, we certainly always advocate that we want the immunity from the influenza vaccine to be durable and last to the end of influenza season, which is typically March, April. So we want that durability for that 6 months. We really do recommend, probably no different than other flu years, to get it maybe October, so mid to late October, and you should be fine. You should have that durable immunity from the influenza vaccine through to the end of influenza season. Right now, luckily, there is not a lot of influenza activity in the United States. Also, remember that when you do get your influenza vaccine, we need to allow 10 to 14 days really to build up the antibodies and to build up the immunity that you get from that vaccine as well. So.
You're going with me next week, Jill, to get your vaccine. Are you ready?
Yes.
We held each other's hands last year.
Yes, yeah, we are.
We'll be socially distanced, though.
You need 2, probably.
What's that?
You probably need 2 shots.
I might. Just for fun. Just to keep it interesting. All right. Okay. Well, we just want to thank Dr. Parrish for coming in today. Nice to see you. Just some final thoughts that you want to leave us with this morning.
If you ever have any questions about anything you've read, heard on the news, please bring it to the attention of your provider. I think oftentimes we can provide you with reassurance, give you a little more in-depth understanding of what you've seen in the headlines. Overall, the absolute risk for something bad to happen to you or to your baby because of this SARS-CoV-2 is very low. The risks with flu are probably higher, so please don't be afraid. Go get your flu shot, take care of yourself, mask, social distance, and you're going to have a good pregnancy outcome.
So don't believe everything you read.
Correct.
Okay, good message. Dr. Hawkinson, final
Yeah,
thoughts?
it is getting cooler, and we aren't going to be able to be spending as much time outdoors. The Chiefs play tonight, so if people are getting together, understand those concepts that we've talked about. Please, if you're getting together, try and get together outdoors rather than indoors. Meet in the small groups to watch the games. Mask if you can. Masking in the household, as long as you're not actively eating or drinking, is going to be another important factor when you are in those get-togethers. So if you can continue to do those things, hopefully we won't see that continued surge and increase in cases that we have been seeing.
All right, thank you both. Well, tomorrow we're going to be talking about this. The CDC reports that a body mass index of 30 and above increases your risk of severe illness from COVID-19. So we have bariatric surgeon Dr. Jennifer McAllister and psychologist Dr. Ashley Rhodes. They're going to update us on the risks and reasons for obesity, plus how COVID-19 is putting some people in danger of life-threatening eating disorders during this time. And Dr. Hawkinson just mentioned tonight, Monday Night Football, starring, of course, Super Bowl champions. Yep, we're excited, so go Chiefs. And so we wanted to show how everyone here at the health system is showing their Chief spirit and of course staying safe. So this is Cliff Irwin. He is he's our videographer. We love Cliff, and he actually doesn't just wear his Chiefs mask. He wears goggles. He came in the other day with goggles on, so he always plays it safe. So so we love that. Okay, so then Miranda, she's here at the health system, and she says she is smiling big time behind that Chiefs mask of hers as she serves up coffee here for us. And then Kendall says this is one of 7 Chiefs masks, one I guess for every day of the week. Kendall, he wears these all week long, and so we want to thank all those folks for sending those in, and thank all of you for wearing your mask. Keep sending in your mask pics, and of course, go Chiefs tonight. You can send those pictures in, by the way, at KU Hospital, or email them to Medical News Network at kumc.edu. So we're talking flu shots today. So Dr. Hawkinson was involved in this really cool PSA courtesy of the Royals. It's called Come Back KC, and it's just reminding us all to get our flu shots. So anyway, take a look at this. Have a great day. Stay safe. We'll see you tomorrow.
It's time to get your flu shot. Put on your game face, gear up, protect yourself and your community against the flu.
This year, more than ever, getting a flu shot matters.
Protect yourself, your family, and your community.
Flu season will be here fast. The best time to get your flu shot is now. Getting a flu shot will not protect you from COVID-19.
But people who get the flu may be more susceptible to a severe case of COVID-19.
By getting your flu shot, you can ease the burden on our labs, our hospitals, and our healthcare workers.
And a flu shot means you reduce your risk for symptoms, severe illness, and being hospitalized.
Get your flu shot and maintain the pillars of infection prevention to stop the spread of flu and COVID-19. Wear a mask, maintain social distancing, and wash your hands frequently.
You heard the doc. Do your part. Let's go, Royals fans. Get your flu shot.